So this is the Pediatric Ventilatory Management Station for the National Registry in first person. We're going to walk you through the skill so that you can see exactly how this station is supposed to be done. So the first thing you will do is your BSI, so make sure you have gloves and eye protection on. You will come and open the airway manually, and you will insert an OPA, displacing the tongue. Make sure that that is inserted correctly.
The examiner now informs the candidate that no gag reflex is present and patient accepts the adjunct.
So now that your patient has accepted your adjunct, you need to connect your mask and your pediatric BVM. You want to ventilate this patient 1 every 3 to 5 seconds or 15 to 20 breaths per minute. 12 to 20 breaths per minute, sorry.
The examiner now informs the candidate that ventilation is being performed without difficulty and that pulse oximetry indicates the patient's blood oxygen saturation is 85%.
So because the sats are so low, we're going to hook the patient up to oxygen. So our BVM connects here. We're going to turn our oxygen up to 12 liters per minute, and we're going to hook up our bag. Continue ventilations. You will ventilate for 30 seconds.
Breath sounds are clear and equal bilaterally, and medical direction has ordered intubation.
So from here, you'll have your partner take over bagging so that you can prepare your equipment for intubation. First thing I'll check is my blade. I want to make sure that the light is on and working and that everything is nice and tight. That your handle as well as the proper size. This is a pediatric handle. Make sure you have the appropriate size tubes ready. I've got a 4, 3.5, and a 3 ready for this patient. This is for a patient that's under 2 years old. I've also got a backup airway, a keying airway for a pediatric patient. My tube holder looks like I'm ready to go. When you're ready to intubate, you advise your partner that you're ready to intubate. He'll remove the adjunct, and I'm ready to go. Make sure the patient is in sniffing position, so you have a pad under the torso. Displace the tongue with your blade. Don't use the gums as a fulcrum. Visualize the cords, make sure that you can see those. Advance your tube. This is a size 4 tube. 4 times 3 is 12. At the teeth is where you want this tube. Remove your stylet. Have your partner continue bagging. If you'll hold that tube as well, Steve. From here, you're going to auscultate for lung sounds. And also over the epigastrium.
And with proper tube placement, what would you expect to hear?
You should expect to hear clear and equal bilateral lung sounds and nothing over the epigastrium. And from here is when you want to use your pediatric tube holder and secure the tube.
Critical criteria for this station includes failure to initiate ventilations within 30 seconds after applying gloves or interrupts ventilations for greater than 30 seconds at any time. Failure to take or verbalize body substance isolation precautions. Failure to pad under the torso to allow neutral head position or sniffing position. failure to voice and ultimately provide high concentration oxygen, at least 85%. Failure to ventilate patient at a rate of 12 to 20 breaths per minute. Failure to provide adequate volumes per breath. Maximum 2 errors per minute is permissible. Failure to pre-oxygenate patient prior to intubation. Failure to successfully intubate within 3 attempts. Uses gums as a fulcrum. Failure to assure proper tube placement by auscultation bilaterally and over the epigastrum. Inserts any adjunct in a manner dangerous to the patient. Attempts to use any equipment not appropriate for the pediatric patient. Failure to manage the patient as a competent EMT. Exhibits unacceptable effect with patient or other personnel. Uses or orders a dangerous or inappropriate intervention.
All right, so this is the Pediatric Ventilatory Management Station for the National Registry exam. Usually this is for the patient that is under 2 years old, so this is our patient here. And we'll get started. First things, BSI. So I've got gloves, my glasses. I'm going to open the airway manually, and I'm going to insert an OPA, displacing the tongue.
Examiner informs the candidate no gag reflex is present, and the patient accepts the adjunct.
So the patient's accepted my adjunct. I'm going to bag this patient on room air, 1 every 3 to 5 seconds, 12 to 20 breaths per minute.
Examiner now informs a candidate that ventilation is being performed without difficulty and that pulse oximetry indicates the patient's blood oxygen saturation is 85%.
So now that my patient's sats are in the 80s, I'm going to hook it up to oxygen. 12 to 15 liters per minute. Continue bagging with my reservoir attached. This will go on for 30 seconds.
Breath sounds are clear and equal bilaterally, and medical direction has asked for intubation.
Okay. So I'll have my partner take over, bagging my patient, 12 to 20 breaths per minute, 1 every 3 to 5 seconds, while I inspect all my intubation equipment. So first I'll look at my blade. I've got a pediatric handle and a size 2 MAC blade. Make sure the light is working, that everything is nice and tight, and it's going to work for you. I've got 3 different tubes here. I've got a 3.5, a 4, and a 4.5. For this intubation, I will use a 4. My stylet is in, and I've got my backup airway ready as well in case of not being able to get that put in. This is a cuffless tube, so I don't need to inflate it. Make sure that it's ready to go once you've pulled it out of your bag. So now that I'm ready, I'll inform my partner that I'm ready to intubate. Okay. I'm going to pat the patient quickly under the torso, put them into the sniffing position. Advance my blade to visualize the chords. Don't use the gums as a fulcrum. And insert my tube. This is a size 4 tube. 4 times 3 is 12. Remove my stylet, don't let go of your tube, and have your partner connect the BVM. Continue bagging the patient. There you go. From here, my partner wants to hold that. I'm going to listen for lung sounds. I want to hear clear, equal bilateral lung sounds, and also listen over the epigastrium to see if I'm in the esophagus. Shouldn't hear anything over the epigastrium. Now that we've listened to lung sounds, we know that the tube is in, we can secure the device with a pediatric tube holder. That's that. Okay.